Dr. Sheldon Jordan. He's a neurologist in Santa Monica, California, and is affiliated with Providence St. John's Health Center. He received his medical degree from the David Geffen School of Medicine at UCLA and has been in practice for more than 20 years. Dr. Jordan is a graduate of Brooklyn Tech Institute, Industrial Design, and completed paramedical studies at Harvard University. Dr. Jordan has published research in behavioral modification of autistic and developmentally disabled children at the Kennedy Institute and Johns Hopkins Hospital. Through his research, Dr. Jordan has developed recovery and educational programs for patients with symptoms of schizophrenia and major depression. So I'd like to introduce Dr. Jordan, where he's going to talk to us today about transcranial magnetic stimulation. Dr. Jordan.
Thank you. So today is going to be a fun talk. We're going to be talking about depression mostly, although there'll be plenty of time for questions and answers, so that if you want to get into some of the other exciting topics that are relevant, we'll have plenty of time to do that. So there'll be a lot of exciting things to talk about today. It should be a really fun lecture. We're mostly going to be talking about depression, and the idea is to give you some images about some of the new developments that relate to depression treatment and some of the coming developments that are going to change this field tremendously. So we're going to keep this very low in statistics, and we're going to keep it very low in terms of the technical aspects of it, and really we're going to talk in some general terms about some of the new developments, which I think will be very exciting. So this is my disclosure of potential conflicts. And I just want to point out before I get too far into the lecture, this program has been going on for many years. We've been working on this at UCLA and through my private practices for over 10 years, and it's involved a collaboration with UCLA and Harvard, a very large research staff, so I have 9 people working with me full-time to pull this material off. It requires a lot of computation skills and just people from different areas to collaborate effectively to bring this forward into clinical practice. Here's just a partial list of some of the people that we work with over the years. It's a very big cast, a very talented task. First of all, we're going to talk a lot about depression, and just so we're all on the same page, let's just go over a little bit about a definition. Depression is characterized by negative affect and beliefs, anhedonia, anergia, not much motivation, a sleep disturbance, rumination, excessive thoughts that keep recurring, and is often comorbid with anxiety. Now really, we're talking about probably several diseases here. There are probably different things that cause depression, and we kind of lump them together. And that's a little bit of a problem, because if you're trying to get a treatment that's specific as to an underlying cause, we may be treating some and missing others. One thing that's very important about depression is it's not a static problem. It tends to worsen. So over the course of a lifetime, people tend to get increasing relapses. The depressive episodes, the time between depressive episodes becomes shorter and shorter, and the severity of each episode becomes worse. 25% of the patients are chronic and completely resistant. And here's something that I think is an important part of this lecture, is when you're looking at people who are depressed in middle age or older, it becomes very difficult to tell who's actually showing early signs of a dementia. And I think that's where some of the technology I'll show you can come to our help. So we know that the treatment for depression is not as good as we would like it to be. And probably many of you are familiar with the STAR-D report that's now several years old, which basically says once you've tried a few antidepressants, adding yet more antidepressant is really not going to help. So generally speaking, you can expect a remission rate in perhaps 25% of the patients that you treat with medication and with psychotherapy. There are many, many failures. So we need to do better. So sometime after the STAR-D report came out, a little bit over 10 years ago, people started to look for alternative treatments. And one of these is repetitive transcranial magnetic stimulation. So we're going to call this TMS for short. Okay. So the idea here, think of your high school physics. So you'll remember that if you take a magnet and you suddenly change the magnetic field, it can induce a current in a conductor that's underlying the magnet. So in this case, if you put a magnet over the scalp and you suddenly change the magnetic field, you can stimulate the brain non-invasively. So you're electrically stimulating the brain using a magnetic type of treatment. And that's what TMS does. Now, the TMS treatment was designed initially to be kind of simple, so that it could be performed easily in a psychiatrist's office, for example, and that it wouldn't require any kind of expensive or difficult to use equipment. So the plan was, let's treat everybody's head like it's an average head. And let's, for the time being, forget some people are men, some people are women, some people are righties, some people are lefties, some people have thick skulls, some people have thin skulls. And here's the worst part, is that the treatment target is different in everybody. So there really isn't an average brain. So the cortical representation of depression is not in exactly the same place. Nevertheless, to make it simple, TMS was started with the idea that there was such a thing as an average head. So the way it would work, and this is sort of shown on this diagram here, is they would put the magnet over the part of the cortex that has to do with twitching the thumb. And that's kind of a nice place to put a magnet because you have immediate feedback that you're in the right place. So you put the magnet over the thumb area, which is the opposite hemisphere, and you start turning up the magnetic energy until you see a thumb twitch. And you say, okay, now I've learned how much magnetic energy it takes to actually stimulate this person's brain. And then what they would do is take the magnet and just arbitrarily move it 5 centimeters forward, with the idea being that most people's target for depression is 5 centimeters in front of the thumb twitch area. So this concept was called the 5 centimeter rule. And this is the basis of all the original TMS treatment. So it's basically, the idea is, if you take your average person 5 centimeters in front of the thumb twitch area, you're going to find the area that you need to treat for depression. So if you look at all the studies that have been published, which includes thousands of patients now over the years, so this research started in the 2000s, and over the last 18 years, there's been an accumulation of a lot of experience around the world. And here's the meta-analysis of all the studies that have been done up through 2013. Basically, an 18.6% remission rate. Remission rate. So, not great. That means about 80% of the patients escape this treatment. So TMS done in the routine fashion with the 5 centimeter rule is pretty iffy. And I think it's the basis of that this technology has been somewhat slow to be accepted by the community. Why the poor remission rate? Well, let's look at some of these issues. Well, we already alluded to the fact that one size probably doesn't fit all. Like, not everybody's depression target is going to be 5 centimeters in front of the thumb twitch area. The other thing is what I call poor quality assurance. The initial equipment was very twitchy in terms of where you'd place the magnet effectively on a day-to-day basis, because it would take, let's say, 4 weeks or 6 weeks of treatment, 1 hour a day over that time frame to stimulate the brain enough to get a change. But the way that the equipment was initially designed, each time you place the magnet, it's a slightly different place, because the equipment that was being used was just kind of squirrely that way. So another reason was the failure to treat comorbidity. Well, for those in the audience who treat depressed patients, you know that every patient is different because they have comorbid problems that are very significant. There may be addiction, there may be anxiety, they may ruminate. My life is terrible, I'm a bad person, I'll never be able to succeed in life, and those thoughts keep happening over and over again, and even though you might be treating a good target, they talk themselves into a negative flight down. That's another reason why this treatment fails, is that you're not treating things outside depression that are important. And the failure to account for the cognitive state. What we mean by that is, people would come into a TMS center and they'd listen to music when they were getting a TMS treatment, or they'd fall asleep. Well, falling asleep is clearly bad because a sleeping brain is not a treatable brain, right? Everybody knows that. So, but the other part of it is, besides keeping them awake, is if you engage someone in an activity that is different from the target you're interested in, you actually suppress your target. So if you listen to music, the auditory cortex is alive, but the other parts of the brain are suppressed. So there's this surround inhibition. This is another thing that you learn from your high school biology, that one part of the brain is stimulated, the other parts of the brain are inhibited. So if you stimulate the auditory cortex by having them listen to music, you're not really stimulating your target. And then how about the right-handers versus the left-handers? It turns out left-handers have a different localization, maybe a different hemispheric localization than right-handers. And here's, of course, the coup de grace, the failure to differentiate depression from dementia. We have this concept in psychiatry and neurology of so-called pseudo-dementia, that someone comes in and they're depressed, maybe a little bit, but their memory is horrible, and they can't make executive decisions, and they're not functional. And we would say that it's the depression causing the problem with cognition. But unfortunately, it turns out that a mood disturbance is very commonly the presentation sign of dementia. So this can happen with Alzheimer's disease, it can happen with frontal temporal lobar degeneration, and with all these NFL players that have had multiple concussions that now come in with chronic traumatic encephalopathy. And these veterans that come out with a piece of PTSD, and maybe they're a little bit depressed, they may go on to have a chronic traumatic encephalopathy, and they may look very much like an anxiety disorder or depression. So conditions that might be traditionally labeled as psychiatric can turn out to be something else. So to recognize these are really all important because the treatments are going to be different. So in adjusting a program that accounted for all of these problems, this is what we're able to do with TMS therapy using some of the technologies I will show you. So we're able to get a 50% remission rate that lasts for an average of 2.5 years. And that's with only 20 treatments an hour apiece. So that could be spread over the course of 10 days if you want to do it twice a day, or 20 days if you can do it once a day. 77% response rate, so that means more than a 30% improvement in their Beck depression inventory. And that's compared to the remission rate of 18.6% with conventional treatment that we talked about. Highly significant difference. So what did we do? We did all the things that were problematic. We took care of all of them. So we don't have them listen to music. We have them do a task that engages the part of the brain that is our target. So we're targeting, in anatomy terms, this is called Brodmann 46. So it's the part of the brain that has to do with creativity, short-term memory, motivation. So it's that part of the brain that we're actually trying to treat. Indirectly, that part of the brain interacts with the cortical representation of depression, which is Brodmann area 25. And I'll show you this later on some of the three-dimensional brains. So we have them do a task that stimulates this. So the task that we use is something that we call an MIC scan. So basically, the patient is given a series of 3 words. It might be giraffe, swan, tree. And they're asked to take their right hand and imitate that word. So take your hand and imitate a giraffe. Take your hand and imitate a swan. and so on. So it requires creative thought. And then after so many minutes, we give him the same set of words again, and we say, choose a different word than you chose last time. So now it's short-term memory. Plus they have to choose a word, so it's executive decision making. So you see all the elements that are in Brodmann Area 46 are stimulated by this task while they're getting TMS. So we're internally generating activity in that part of the brain we want to target, and externally we're treating it. So we get a better treatment response. So the other thing we've done is use functional imaging to actually target where Brodmann 46 is, because everybody's different. We'll show you how we do that. The other thing is treating comorbid conditions. So if they're anxious, we want to know that. If they're ruminating, we want to know that, because that's in a different part of the brain. I'll show you. And you can turn off the ruminations directly. So I'll show you how using functional imaging to target the magnet placement works. This is a little bit of an animation that shows you. So as before, we're very interested in finding the thumb twitch area because it tells us what that dose is, how much magnetic energy. So we can find exactly where the thumb area is using functional imaging, and we can put that on a three-dimensional image in virtual space. So this is a real person's head in virtual space. We can then measure where that motor cortex is compared to surface landmarks like the nasion, the ear crease, the inion. And once we have those measurements, we can go back to the real head, take those same measurements from the same landmarks, put an X marks the spot, and now the magnet is centered over exactly where we know the function is. So every function in the brain that is accessible can be found in this way. So we do a functional image to find out where the function is, then we go to virtual reality to place that on the patient's head, and then we put the magnet on. So that's basically how this works. That make sense? Okay. So let's do a little bit of a digression and talk about functional imaging, because this is how we actually find out where is everything located in our brain. We don't want to just see structure, we want to know where do things happen so that we can accentuate those areas with specific targeted treatment. So I'm not going to go into the specifics of all this, but when we say advanced MRI, it's multiple things. We're measuring the size and shape. We can compare each part of the brain with age-matched controls. So if we're interested in the size of the amygdala, the fear center, or the memory area, the hippocampus, we can measure it in any individual and we can compare it with anybody else. We look at perfusion, we look at activity of the brain, and we look at connectivity. All these things can be measured, so it's a whole toolbox. This particular project, it's been actually going on for about 40 years, and I'm not going to bore you with all the details, but we looked at the practicality of actually bringing this to a clinical scanner. So this can be done here in Santa Barbara very easily. If your radiologists are interested in doing this, it can be done. So we looked at a 1.5 Tesla magnet, not a very strong magnet. These are found all over the United States. You can do it at 1.5 Tesla, a weak magnet. You can do it at a stronger magnet. So we looked at one particular site. We're able to complete 100% of the scans. So just about every patient that you send can be scanned. It takes 41 minutes. We've looked at a lot of patients with different conditions, dementia, head injury, and a lot of depression, anxiety. So when would you use an advanced MRI tool set? Well, first of all, to clarify the diagnosis. Is it depression or dementia? It's important. Navigating for TMS, and we're going to talk a little bit about focused ultrasound and the next generation of regenerative medicine for some of these conditions. We want to know what the comorbid conditions are. So if someone's depressed, are they also anxious? Are they ruminating? Are they addicted in a craving state? Can we target that aspect as well? Those can all be found by functional imaging. Plus, we can monitor the effects of treatment. So how often does it change the diagnosis? Half the time. So you think that you figured this out by doing a good exam and listening to your patient, which is, of course, very important. But what you sometimes don't pick up, and I've done a lot of psychiatry over the years, I'm sure Dr. Erickson will chime in on this one as well. You see a patient a few times, and you still don't really know that patient. you may not realize that they're ruminating all the time, or they have a very profound anxiety disorder that comes out under certain circumstances, or there's an addiction, because they might be very good at covering that up. So sometimes it'll take many, many visits before you really find out that something is really going on. What's nice about functional imaging is it doesn't require the patient's cooperation. It gets right past their defense mechanisms, because there's no way that the MRI scan can't see what's going on inside their head. So now the clinician has an additional clue that they can work on. So you can uncover things that might have taken you many weeks. You can uncover it much faster. That's the efficiency of all this. Just a little bit about just measuring size and shape. Now obviously you look at that scan on the left versus the one on the right, you can say, okay, well that person on the right has some brain atrophy, there's some loss of brain tissue. But isn't it nice to say that they're actually at minus 2.7 standard deviations compared to their age-matched controls, and they're at 0.35 percentile. Now that's nice if you're trying, and you can also look at the hippocampus, for example, if you're interested in memory impairment. With schizophrenia, there are different parts of the brain that show atrophy. There's actually fairly robust literature looking at a variety of psychiatric conditions that you start measuring the size and shape of different parts of the brain, you find out there are differences. So in schizophrenia, the Brodmann areas and Wernicke areas, temporal parietal junction areas, definitely show a change in anatomy. Whereas with depression, which is the focus of today's lecture, it's Brodmann area 25. It's the subgenual orbital frontal region that shows a loss of thickness of the cortex. And we now know that there is excessive synaptic pruning. There's an inflammatory component. And this is why people tend to get worse over time. They become more refractory. There are actually changes in the brain. Depression is not a static condition. It is a progressive condition, and you can measure it. Of course, if you're looking at PTSD, we know that the amygdala, the fear center, tends to be affected as well. Now, if you look at the top scans going across the top row and the bottom row, you can look at that cross-eyed and you say, they look the same to me, because your eyeball is only so sensitive. But if I were to tell you that with advanced imaging, we can look at the hippocampus of this patient and say that there's a 30% improvement. So this is a patient that was in our Pfizer-supported tyrosine kinase inhibitor study, where we can actually show that people with Alzheimer's disease, you can actually get brain tissue to recover. And the patients on repeatable psychometric testings like an R-bands will actually show improvement. So there is a treatment for Alzheimer's disease, and we're going to be publishing this material very shortly. So this is a 300 case study. It's mixed Alzheimer's and Parkinson's disease. But if you want to use advanced MRI as another measure, you need to be able to quantify those changes and compare it with the patient's own baseline as well as with the expected norms for that age. So arterial spin labeling is another part of the toolbox. And arterial spin labeling basically, in my mind, replaces PET and SPECT. What it does is it looks at function by way of an indirect marker. So in a normal condition, in a stable condition, brain function and brain perfusion is matched. So if the brain is more active, it's burning up glucose, it requires metabolites, it requires more blood to be delivered to make that happen, right? So there is a coupling between the brain demands and the blood vessel able to provide that increased blood flow. So that's called neurovascular coupling. And you can use increased perfusion to show you if the brain is actually being perfused in an appropriate fashion or not. So this is the way that it works, a little quick animation. You put a tag, a magnetic tag at the base of the brain. The blood vessels go into the brain. We're interested in a particular slice, which is shown in that upper box. And if we just look at that one slice, we do a subtraction, we can actually come up with a scan that we superimpose on an anatomical scan that can give us a quantification of how much blood flow there is and therefore how much function. And we can say that's 62 mils per minute per 100 grams of tissue, for example. So it can be very precise. There are some problems technical problems in doing this correctly. We don't necessarily need to go into that. But let me show you some real-life patients. So here's a patient with depression, and very typically they have an asymmetrical or bilateral decrease of signal in the prefrontal region. You can see, does the arrow show up there? Okay. So if you look at the area here, right, there's a decrease of signal compared to the opposite side. So that one prefrontal region shows diminished activity. And if you look at a side view, if you look at the front part of the head, you can see all the reds here, which is less signal, and there's also a dropout of signal compared to the posterior aspect of the brain and the cerebellum. So prefrontal decrease of signal is very typically seen with depression. And you can use this to track therapy. So Dr. Erickson's seeing this patient 2 weeks after he started TMS therapy, and he's saying, you know, Dr. Erickson, I have some good days, I have some bad days, but I'm not sure. I'm not really sure if I'm better. If you do a scan at that period, and this will turn out to be a successful treatment, what you find out on the right side, that area of low signal is now filled in. So you can use this to monitor therapy before it's clinically apparent. So patients who have depression that are successfully treated, and this will happen if you use medication therapy, or if you use TMS therapy, or use focused ultrasound, or whatever you use, it'll actually show a change before it's clinically obvious. And it's only because patients are tough to pin down. They're tough. We've all been there in the trenches talking with these patients. Oh, doc, I'm not really sure I'm better. And also, you know, in the relationship they have with you, sometimes they're a little fearful of saying they're better because at some level they may fear that, well, maybe the doctor's not going to treat me anymore because I'm better. I don't know, there may be some of that going on in some people. So this gives you another measure that's independent of that type of problem. Now this is very different from some of the dementias. So frontal temporal lobar degeneration. Yes, Dr. Erickson.
Just one question. So your tag is using a magnet to affect the blood in a way where you can follow where it goes in the brain and measure it.
Yes, so each little hemoglobin molecule is basically being affected by the magnetic field at the skull base. And as the blood takes that tag, that magnetic tag, into the brain, we can track it. So it's a way of, without giving an injectable radio tracer, we can look at blood flow. So isn't that nice? You can repeat this any number of times without radioactive tracer. It's cheap, reproducible, and it's nice to be able to use in this circumstance. So I showed you a patient with depression. Now look at frontal temporal lobar degeneration. These are not rare. These are patients that you're seeing in the 50s and 60s who come in with depression. You know, in the old days, and I'm going back a long way, we used to call this melancholic depression, right? I don't know if they still use that term, but you know, these people are 50 or 60, and are they depressed or do they have an early dementia? It's nice to have an independent tool. You can see the dropout of signal in the prefrontal region as well as in the posterior aspects. Different from Alzheimer's disease. So Alzheimer's disease has a dropout of signal not in the frontal regions, but in the posterior regions, temporal parietal regions. So you can tell Alzheimer's disease from frontal temporal lobar degeneration from depression. They're all different. But the patient may present to you at early stages relatively indistinguishable. So also we can look at injuries, chronic traumatic encephalopathy. So I have a long relationship with chronic traumatic encephalopathy. I was the neurologist for US Soccer for many years, and I wrote some of the original papers on this. Of course, the NFL players are very much in the spotlight right now. We see many of them, and they can present as a psychiatric appearing illness frequently. They may be irritable. They may look like borderline personality. They may be beating up on their spouse. They may be very depressed. Now, is it simply depression or is it chronic traumatic encephalopathy? Tough to figure out. It's nice to have an independent measure that can help us figure that out. I want to say a little bit about transcranial ultrasound because this is going to be happening in the next 10 to 20 years. It's a very interesting new technology. Now this can also stimulate the brain besides the magnetic treatment. So we can use ultrasound waves. So just mechanically distorting the brain tissue a little bit can actually stimulate it without damaging it. But you can also use this technology to deliver exosomes. So exosomes are the little particles that come out of stem cells, and they have microRNA that by way of epigenetic mechanisms can change the DNA expression in the cells in the environment that you inject it into. So let's just say you want to have more serotonin transporter in the cortical representation of depression. How would you get it there? Well, you can have the right microRNA in an exosome, and then you can deliver it using focused ultrasound, because what focused ultrasound does, and this is another application of arterial spin labeling, ASL, is that you can use the arterial spin labeling to show that the ultrasound targeting was exactly where you wanted it. So here's a patient, you have left versus right, so this is the same patient. If you look at the base of the brain, and we're talking about this area here, is the hippocampus. So if you know in those patients with early minimum cognitive impairment, before they really have a diagnosis of Alzheimer's disease, memory impairment is their presentation, right? So is that dementia or is it pseudo-dementia? Because they might be a little bit depressed. So it's nice to have another treatment that you can use. So the focused ultrasound will show that there's an increase. Look at this area here, how much more bright yellow it is. And we can tell you that there's a 4 times increase in blood flow to the hippocampus specifically in this patient after treatment with ultrasound. So we use the ultrasound to prove that we're in the right place. And for the coma patients, you probably read about in the newspaper that we've been recently dealing with, we can target with ultrasound and show that the targeting was correct using ultrasound afterwards. But also we can increase the blood flow specifically to that area. So if you want to give exosomes to the area of injury, we can get the exosomes there specifically. So bold imaging, well, what you have to know about here is if you look at a brain and you look at so-called bold imaging, just at rest, you'll see from this animation, this is actually a real patient, what you're seeing is different parts of the brain lighting up or not lighting up because as you're sitting there in this room right now, different parts of the brain are turning off and turning on repeatedly. You have this concept that consciousness is going in a constant level, but that's not really how your brain works. You're sometimes having your auditory network turned on, sometimes you're having your internal rumination network turned on, sometimes you're having your executive network. So different networks are turning on and off, but somehow the brain has a way of knitting this all together so you have a sense of continuous consciousness, but that's not really how the brain works. The brain is turning on and turning off these different networks repeatedly. And one thing that's required to keep these networks turning on and turning off is having this neurovascular coupling working properly like we talked about. Now, it turns out that there's a little nucleus in the brainstem called the locus ceruleus, which sends axons all over the brain that helps facilitate this neurovascular coupling. And guess what? This is a very, very vulnerable target. So it's one of the first places that dies with Alzheimer's disease and Parkinson's disease. So knowing that, we can look at the loss of neurovascular coupling as a very early test for dementia. And this is something that we developed in our laboratories that we've presented this at several meetings already. But if you look at the left, that's me, by the way. I'm calling myself normal. Let's just go with that for now. All right. But what you want to see is you look all over my brain, including my hippocampus, because I think I can remember where I am right now. So at the base of the brain here, if you look at the hippocampus, which is here, there's lots of activity. If you look at someone with minimum cognitive impairment, they start to lose the activity in the hippocampus as well as other parts in the brain. And when you get to a stage that's frankly demented, and this is just a stage 1 dementia, this is mild dementia, the neurovascular coupling is lost. So you can do this at a very early stage and differentiate depression from dementia, yes.
So what's actually being measured here?
So here you're looking at the amount of variability in blood flow on demand, so that neurovascular coupling. When the brain turns on and turns off, and I'm showing you those networks that are constantly turning on and turning off. But if those networks are turning on and turning off, but there's no neurovascular coupling, you get no variability in the signal. So the brain wants more blood, but it can't get it. So that adds an additional oxidative stress. And that's one of the reasons why people with these dementing processes eventually will accelerate, because this is an early lost phenomenon, that the ability to get blood flow on demand is lost. So the brain wants more oxygen, it wants more glucose, it can't get it. So that produces a stress on the cell that adds to additional damage. But I was just showing that that's a way that you can differentiate some of these conditions. Now we can just look at resting bold, and I just want to show you a relatively normal person here. So resting bold, again, many networks are turned on, and we can look at each network individually. So there's one that we look at a lot called the default mode, and this is what you do when you're just not really paying attention to the environment, you're not doing a task, you're sort of internally ruminating a little bit, thinking about, this is me, I'm in this room, the world is out there. So it's your internal thoughts, your self-thinking, your self-identity, your sense of place in the world. That is the default mode. And we can see all these different components of the default mode. This is just someone in a scanner at rest, not doing anything. They will go through these different networks. And you see this kind of normal posterior component and anterior component. But here's a patient with frontal temporal lobar degeneration. You lose that frontal temporal component early on. And that's different from Alzheimer's disease, where in the posterior part of the brain, early on, you actually get an increased signal because the brain somehow recognizes that it needs to generate more brain activity to perform a task. So there's an initial attempt to compensate, and you actually get more activity in certain parts of the brain. Afterwards, that all falls apart. Now, in patients who are ruminating too much, that front part of the brain, and I said that's sort of your self-talking, self-recognition, this is important to me part of your brain, all right? In people who ruminate, they're overusing that, and you can see hyperconnectivity in that part of the brain. So it shows up as too much activity in the front part of this default network. Interestingly, you can look at this to monitor treatment. So whether you're using medications or a psychotherapeutic approach or TMS, when patients are starting to improve, they lose that excessive signal in the frontal part of the brain. That rumination part tends to slow down a little bit. And again, this may happen before it's clinically apparent, because they have their good days and bad days, and sometimes it's hard to recognize that. So you'll see this before, several weeks before it's clinically apparent. Here's a patient that, very interesting accident in nature, so to speak. We happened to scan this patient one day before he took an overdose. He was in a addiction treatment center, and he was telling us that, I feel pretty good, I'm getting along with the program. You know, they all have a story, right? So what we found on him is he has, this looks like a ruminator, right? You see all that excessive activity in the front part of the brain. That craving will have that sort of representation. It's very much like rumination. So rather than thinking, oh, I'm terrible, my life is bad, I'm going nowhere, it's not that kind of a rumination. It's like, where can I get my next whatever? Who can I call to score on this? And I really need something, right? So those thoughts are going over and over in their head, and you can see that representation with functional imaging. So there's another way of looking at the brain where we can put an area of interest anywhere we want and see how well it connects to other areas. So this is very helpful when we're looking for anxiety disorders, for example. So we can put a seed in the amygdala here, which is this little red dot. So we draw this. And we basically say, okay, brain, we're going to put a little spot here, and we want to know what other parts of the brain will give us a bold signal that corresponds to that. So normally, in someone who's not anxious, and this is me on the bottom here, by the way, again, we're taking some license here. I'm going to be the normal again. So if you take a normal person, there's very little connectivity to the rest of the brain. So if you put an area of interest in my amygdala, I'm not anxious, and so nothing happens. But look at the top one. You see all this activity in the brain stem. You see the Brodmann area 25 again, the subgenual orbital frontal region, cingulate region, and by the way, also the cerebellum can be activated in anxious states, as well as the brainstem. So you can really get a sense of how patients are feeling in terms of anxiety. And we can map out these anxiety areas, and we can use this as another target for TMS. So we can find out where that cingulate area is. So if we want to turn on, in this case, this is the cingulate filter. Most people who are anxious, by the way, they're not able to filter out their anxiety. So we can find out where that area is supposed to be, and we can target that with TMS. Now, another thing that we can look for is the cortical representation of cognitive behavioral therapy. So where is that? We can find it. You have them do CBT in the scanner, and you see what part of the brain lights up. So we have a very specific protocol. We basically have them do a CBT task to replace their negative thoughts with positive ones, right? So here's sort of the baseline condition, and we're just looking at the prefrontal area right now. And very typically, if they're anxious, you'll see some activation in that midline cortical area in the prefrontal region. But here's something that you didn't see in the baseline, is now you see something in the ventrolateral area, which is the part of your brain that gets activated when you want to reappraise or reframe a thought. So this is the patient who's saying to himself, I can get through this. I can cope. I can do better. I've been through worse before. It's that part of the brain that turns on. So it gives us another target for TMS. So now we can go to that area, stimulate it with TMS, and we can work along with whatever CBT the patient is doing and get a better outcome. I want to kind of end up talking about how do you get to Brodmann 46. So Brodmann was this anatomist many years ago who broke the brain into different neuroanatomical areas, but it turns out that they're functionally different. So area 46, which is in the prefrontal area, is that part of the brain that has to do with creative thinking, short-term memory, and imagination, and it interacts with the cortical representation of depression. So that's an easy target to get to with transcranial magnetic stimulation. So here we show you in the crosshairs where that is, while a patient's in the scanner doing that task where they imagine making shapes with their hand, right? So we can actually find that area, and then we can target it with TMS. Now, it's different in everybody, and in fact, this target is off by an average of more than 2 centimeters from the 5 centimeter rule I told you about. So this is another reason why TMS often fails, is because you're off target. If you have a magnetic treatment area that's only 2 centimeters wide by 4 centimeters long at a particular depth, and you're off by 2 centimeters, you're missing, right? So if you can be spot on, it's helpful. But here's a patient that you missed the entire hemisphere. This patient was treated with standard TMS, actually using a device called a BrainsWave device, which is very broad field. You think, I can't possibly miss the treatment area with this magnet. Well, the problem is that his Brodmann 46 is in the opposite hemisphere. This is in the right hemisphere. And the treatment target that people tried in this case was the left hemisphere. They were off by a whole hemisphere. You wouldn't have known that unless you did this first. So now he's going to be retreated going for his right hemisphere. The last thing is diffusion tensor imaging. So we can actually look at some of these pathways. We can look at the axonal connections. And if you look on the left, we can actually take out the fornix, which is the output pathway of the hippocampus. And on the right side, you can see what an Alzheimer's patient would look like. The other thing is we can look at biochemistry. So magnetic resonance spectroscopy, we can look at the chemical signature of synaptic connections. And when you start to lose synaptic connections, you start to lose signal that's associated with those. So here you can see that top arrow shows you a particular peak that has to do with healthy synapses. But in Alzheimer's disease, if you look at that peak and you take a ratio of that peak with the next peak, it's at 1.4. So this is at the transition from minimum cognitive impairment to dementia. The patient has lost so many synapses, you can see the signal change when you look at a chemical signature of that person's brain. You can use this information to differentiate different types of dementia, but here's the really cool thing, is with special editing techniques, you can actually start to measure neurotransmitters in a living brain anywhere you want. So it turns out with depression, there's a loss of glutamate, the excitatory chemical in the prefrontal region. So we can look at the glutamate peak, or we can look at the GABA peak. And in Alzheimer's disease, you basically lose the glutamate peak in that precuneus area that I was talking about. So just to sum up, and we'll have plenty of time for questions and answers, I would just wanted to let you know that depression is common. It's often progressive and disabling. Depression is not presently treated with enough success. We want to do better. And technology is available to integrate advanced MRI, TMS, and ultrasound into practice for improved outcomes in treating our depressed patients. So those are all the things I wanted to say, and now I'll just throw it open to questions. Yes?
When you mentioned new treatments for Alzheimer's, were you talking about medication or TMS or something else?
Well, for Alzheimer's disease, we have 3 main projects going on right now. So one is this tyrosine kinase inhibitor, so it's a repurposed leukemia drug, which is a pill. We're using Bosolif, which is a Pfizer drug, that what it does is it turns on the intracellular disposal of these abnormal proteins that deposit. So the abnormal amyloid and tau, which is toxic, can be disposed of more rapidly by using this chemical. So we have a study that's going to allow up to 300 patients, but so far it looks like most of the patients have actually had improved psychometric testing and improved MRI scans when we measured them. This has been going on for a couple of years, and we're going to probably add a few more patients, but that's one study. The other one is using focused ultrasound. So the idea with focused ultrasound initially was to break up the amyloid plaque using the ultrasound. The ultrasound technique was actually devised for breaking up clot with acute stroke. So that same equipment is available for breaking up these amyloid deposits. But it also turns out that it increases perfusion locally, so we can do the ultrasound while they're getting the tyrosine kinase inhibitor and get more drug to the hippocampus. So we've done that. So focused ultrasound with the medication to get more to the hippocampus in Alzheimer's disease and more to the substantia nigra in patients with Parkinson's disease. So we've done that experiment. We're in the process of publishing that material. And the third thing is delivery of exosomes. So we can do epigenetic modification of these different parts of the brain and affect decrease in inflammatory signal and hopefully turn on regeneration by using focused ultrasound to deliver the exosomes in the part of the brain that you want, rather than having to inject them directly with a needle like they've done with the Stanford stroke study. So, yes?
What's the clinical availability?
Well, it's available now. The closest the company that I work with is now negotiating with 800 centers around the country to have this equipment made available. It can be made available on just about any scanner. So I know there's some interest in Santa Barbara in doing this. We had a meeting some months ago with one of the chief radiologists here, and so far there hasn't been any movement, but we'll see what happens there. Your patients right now, the closest would be Santa Monica, unfortunately. But if they can drive down to Santa Monica, they can get the scans are available. By the way, as a teaching tool for your patients, this is amazing. Because you sit in front of your patient with your patient. We go through the scans with you, and the patient and the patient's family can see what's actually happening inside their brain in a way that before it was just sort of ephemeral, right? You'd say, we think this is going on, that's going on, based on the interview and, and whatever testing you did. But for those people who are visually oriented, when they can see the craving is turned on, they can see the rumination is turned on, they can see that amygdala is hyper-connected all over the brain, including the brainstem, and that's why they're anxious, or that's at least a correlate of their anxiety. It's a phenomenal teaching tool clinically. So even if you didn't ever use this for TMS or for focused ultrasound, just having this as a means of looking at your patient's brain, I think the biggest barrier is cost, because right now it's not covered by insurance, so you're looking at something that's in the $2,000 range for a scan, for one scan, yeah.
And is this your group at Santa Monica that is offering clinical treatment now?
This is for what, Alzheimer's disease?
Yeah, right.
Yeah, so I'm the chief investigator for the tyrosine kinase inhibitor, the exosome study, and the focused ultrasound study. But it's in collaboration with my UCLA colleagues, and it's a very big group, as I showed you. Yes?
Is it accurate that blood flow in the brain can change based on the time of day or the activity someone's engaged in or blood pressure?
Yes.
And if that's the case, I'm just wondering how you determine efficacy based on images of blood flow.
Yeah, so you're asking a question about what is the scan-to-scan variability and how much does that enter into our ability to interpret the studies. So I didn't really spend a lot of time on the technical aspects of doing this, but validation studies and reliability testing is very important, and you have to know how much variability is just normal variability. And if you have it done in one scanner or another scanner, or the scanner changes from time and day, there are ways of harmonizing the data so you can account for the variability. So basically, you get enough data in any given scanner at any given time of the day to find out what the expected performance should be, and then you can use that to adjust any variability that you have. You try to scan the patients with the same types of circumstances, same time of day, and so on, and they're given the same instruction set. So we're very aware, and this is a very painful process, trust me, to get this right. And to do this well, it takes so many people and so many years, because all these factors that you're mentioning are very, very important, and you definitely have to account for all of it. Yeah.
You mentioned that sometimes people wouldn't show behaviorally the diagnosis and you would see it on their brain scan instead. And I was just curious how you were actually using that as a diagnosis tool, considering most of the studies done on observing the differences in Alzheimer's and normals or anything else, or actually group studies.
So
there's huge
we now have probably over 1,000 patients we've looked at, and the advantage of this going over 10 years is that we know what the outcomes are. So if someone presented with a particular syndrome, we know what they look like years later because we followed them. The other thing is there are other biomarkers that we can use to correlate and use as a gold standard. So for example, with Alzheimer's disease, you can look at A-beta 42 tau phospho-tau in the spinal fluid. And for those patients who were in the tyrosine kinase inhibitor, they all got spinal fluid analysis. So they all had an independent gold standard biomarker. So there are various ways of trying to get the right diagnosis, but you can use alternative biomarkers that are considered gold standards, but you can also have the ability to follow up these patients over time is really critical. Also the response to therapy. So a lot of these people have been treated with, for example, transcranial magnetic stimulation, and we've tracked their scans before and after treatment, and I've showed you some examples of that. It changes.
Have you done studies also on individuals that aren't diagnosed and seen if their brain changes in the same way?
Yes. So in our database, we have something like 8,000 patients that are normal. And the way that you get normals is various ways. So we've created some of that normals, but we also participate in the Connectome project, which is an international database acquisition for normals. There are also normal databases for elderly people, like with the ADNI study. So there are children databases. So we definitely have to, when we did the validation studies, we not only looked at normal individuals that are age matched and sex matched and so on. But we also looked at different disease entities that have been identified by other biomarkers and compared them with our imaging findings. And we do this all in a double-blind fashion, so there's no examiner biases, and that it fulfills all the statistical requirements to be robust. So this is something we struggle with all the time. You know, we don't want to just show you some pretty pictures. We want to show you, we want to get you some data that's actually diagnostically useful, and we think we're going in the right direction to make it useful. But all the things you're talking about are critical. You know, it's easy to be misled, and it's easy to think you have a tool that's really helpful, and maybe it's not. So that's why you have to do validation and reliability testing.
I wanted to ask you, so you mentioned this treatment is FDA approved. Is that FDA approved for what diagnoses? Would that include migraine headaches? And then also, can you speak about the failed first before you could refer someone to this kind of treatment?
Can I think about the what first?
The failed first, like how far do they have to go and treat
Oh,
it
okay,
in other areas?
So TMS is FDA approved for treating depression. And the original studies, I believe, looked at 2, possibly 3 drug failures. So I don't remember it was 2 or 3 at this point. But typically patients who have TMS, they've tried at least 2 or 3 drugs and failed, and in good doses. Most of the insurers, and Mark, you may want to comment on this because I know you fight with insurers a lot. Many of the insurers will be very careful about asking about medication trials. So they want to know which drugs exactly, what the doses were, and for how long. So they want to know if the patient really had a good drug trial for at least 2, possibly 3 drugs. And so if you look at all of the published protocols on the web for Blue Cross and whatnot, they'll give you some information. You want to make some comments about that?
I think the magic words today are failure of 2 courses of drugs from 2 different families of drugs of adequate strength and duration, which means different things to different insurers. And Brandon, who does this 24/7 for us here in Santa Barbara, some of the insurance companies are also talking about augmentation, which is even an additional course of drugs. But we have found that we've been able to generally get patients covered by insurance if they have had a significant exposure to antidepressants without relief, basically.
Any other questions? Yes.
You had mentioned that if insurance is not covering that, the scan covered, just to get the scan is $2,000. How much does the course of treatments cost?
Yeah.
So if the provider is a panel provider, it's whatever the co-payment is. If you want to look at the rack rate, so I don't have insurance, I'm really depressed, I failed 2 drugs, what do I do now? Okay, so there's a fair amount of variability in pricing in various neighborhoods around the country, and I've been teaching this nationally, so I have sort of a handle on what happens in various places. But in the Southern California market, generally people are going, if you do it the traditional way, not navigated, you need over 30 treatments. It's typically 36 treatments or so. They're usually charging between $15,000 and $25,000. So that's 1 hour a day for 36 or so treatments. They'll often do maintenance therapy several times a year. It's pricey. The way that we do with targeted treatment, it's only 20 sessions. You can get that done in 10 days. I don't know if I should say exactly what my charges are, but we're below that level actually, because we can do it in 20, so we pass the savings on to the patient. So if they were going to be paying out of pocket which is not advisable if you can avoid it. If you're paying out of pocket, we're actually saving them a lot of money by doing the targeted treatment with TMS, because first of all, you're not spending the next 6 to 8 weeks of your life getting TMS treatment every day, right? You're doing this you can do it in 2 weeks, you can do it in 4 weeks, and then you have 2.5 years remission without any maintenance therapy. So I think you're actually saving money for the patient in the short run. It's just that it's front-loaded in terms of cost, and I think that's a little daunting for patients. I think that's the main problem with everything I'm saying today, is the initial cost going in, but patients are, if they understand what the economics look in the long run, they're very happy with this. When they've gone through this process and after 10 days, they're in remission and they're back at work. I mean, think of how much they lost work-wise. $2,000 sounds like a lot of money, but how much is it worth for you to get your life back and to get back being productive? It's a lot more, so you have to look at all that. Now, the other thing they complain about is you have to validate. It's that $15 parking fee that they don't. It's the funniest thing in the world. We're talking about thousands of dollars, and it's like, but doctor, do you validate? What's that? Yeah, Medicare does pay for it. Mark is shaking his head yes and no. But
yes, Medicare will cover it, and no, we don't take Medicare because in California they don't pay enough to actually cover the cost of the treatment.
Yeah, that's worse
in
than
Illinois
I
they
guess.
do. I'm hoping that, and in Illinois we take Medicare, but
Could you speak louder? I can't. And who
it
are you?
it is covered by
Could you
Medicare.
identify? I don't know who you are.
I'm sorry, my name is Mark Ewall. I'm the president of TheraMind Services, and we operate TMS centers around the country,
Here included,
including one here in Santa Barbara. And Dr. Jordan is actually our medical director for neurological aspects. So Medicare does cover it. If California was late coming to the party, I don't know, Medicare is broken into 7 regions. Illinois got approval 2 years ago, and we do treat there. California, Medicare's covered it for about 14 months now. But again, at a rate that almost no one who does this accepts Medicare in California. And eventually what will happen is Medicare will raise those rates until we can start to treat. TRICARE, there's the other thing, the VA will cover it and TRICARE covers it. So for active duty military, it is covered, and we were just approved 2 weeks ago to treat veterans across the country.
And when you say cover, you're talking for depression treatment specifically rather than Alzheimer's?
Yes. And
let me comment on that. So use of TMS for off-label applications. You want to talk a little bit about that? TMS for off-label applications. You want to talk a little about that? Okay.
Including essential tremor. Someone just told me that they're successfully using it at Stanford and somewhere in Virginia.
I wouldn't use it for essential tremor, but we've used it for Parkinson's. There are some targets in Parkinson's, so you go for the premotor cortex. And for those people that have recurrent freezing reactions, it's helpful. It's not particularly helpful for tremor. I've looked at that. So in the realm of dementia, I think it's, as presently utilized, I think it's marginally effective, and I don't particularly recommend it for that application. That would be my take on it, having spent a lot of time and effort with that. I think for dementia nowadays, I would go with a tyrosine kinase inhibitor or exosomes or some other treatment like that. For anxiety, it is phenomenal. It is almost instant. And for mania, you have someone who has a treatment emergent mania, like you put them on, let's say Lexapro, just choose a drug. You put on Lexapro, and they're starting to spin out of control, now you have options, right? I mean, you can put them on Abilify or some other mood stabilizer, but you can, in 1 or 2 days, you can get their hypomania or mania under amazing, it's very, very responsive to that.
Permanently, or he needs touch-ups?
You know, I don't really know the answer. It's a very good question. I don't have the data, and I don't want to speculate, because usually what happens is we use TMS to get acute control, and then they go on effective, then you're buying some time to go on some more effective long-term treatment. So it's typically going to be pharmacological treatment. You know, and also, now with depression, we're talking about off-label things, but there's one thing about depression you need to know about, is depression, it doesn't kick in for, let's say, 5 or 10 treatments, right? So if you have someone who's really suicidal and they're psychotically depressed, what do you do? So again, you might need to use some pharmacological stabilization at some point, but the other thing is I use ketamine for that. So I use intravenous ketamine, we're talking 500 milligram doses, not just 100 milligram doses. But we put them in a ketamine dissociative state for 1 to 3 days, and that buys us time to get other pharmacological agents and TMS. But for hypomania and anxiety, it's very fast. For depression, it's not fast enough. Depression, it's working indirectly. You know, we're turning on the executive part of the brain, but it's the interaction of the executive part with that Brodmann 25 that is actually giving you the emotional benefit. It's delayed. Yes?
Is there a point of magnetic field intensity that may have a negative effect?
So this is a very good question. So every patient feels irritated when you start the therapy, because if you do a magnetic treatment at 10 cycles per second, it feels like a woodpecker on your head. They don't like the woodpecker, but it goes away after a few days. They just ignore it, and they actually feel pretty good in the scanner. So the experience is actually generally positive. Most people can get through the sessions. There is a 1 in 3,000 chance of inducing a seizure by the magnetic treatment. So that isn't necessarily bad, of course, when you're treating depression. I mean, after all, we learned about ECT because it was the post-ictal state that would often release people from their depression. So it's not the worst thing, as long as they're in a protected environment, right? It's a supervised environment, they're in a padded chair. If they have a seizure, you know, they're going to be okay. It doesn't cause epilepsy, it doesn't cause repeated seizures. But it's very frightening. The patients have to know about that 1 in 3,000 chance. I've seen 2 seizures. I've been doing this for over 10 years, thousands of patients. I've seen seizures twice. I guess my odds are if I've seen 10,000 patients, I should have had one more, right? So I shouldn't say that, I'm jinxing myself. But both cases, they were like sort of predictable, and in retrospect, I kind of feel bad that they even had those seizures. Like, one was a patient that was on 10 milligrams of Klonopin a day, clonazepam, and was feeling like, hey, I'm in remission, I'm just going to stop it. She didn't tell anybody. So she came in and she was, obviously that's going to bring out seizures. The other thing was a patient was going to the bathroom and shooting up with ketamine during TMS sessions. It was obviously as an addict. And we missed that one, but we caught on eventually. So, yes.
Do you see an uptick in memory? Especially in
Yes,
Alzheimer's
if they're,
and
yes.
like in beginning stages of Alzheimer's? Like especially short term?
If they have a combined, if it's just Alzheimer's disease without depression, I don't believe that you can expect a lot out of this. We've tried it. I'm not particularly recommending that. I honestly don't think it's worth. I think you should do something else. But if someone truly has, and this is tough, these are very tough patients. If someone has a depression and they have an early dementia, they might benefit. So, sometimes there's a little bit of a guess there, and the functional imaging can help us a little bit. If someone has a very shrunken hippocampus, the arterial spin labeling shows that the hippocampus and the posterior brain is basically shut off. They're not going to respond to TMS. On the other hand, let's say they appear depressed, we do a spinal tap, and they have A-beta-42 positive for Alzheimer's disease. So they have an Alzheimer's disease propensity, but really the main problem is an ongoing depression. Yeah, they'll respond and their memory will probably get temporarily better. Those are tough patients, but we see them for sure, yes.
Do you think that what TMS is doing is inducing neurogenesis, or is there any understanding of the neurophysiology? And could you augment this with ultrasound if that increases blood flow to the area?
We really don't, I mean, that's a very good comment. I don't know if it produces neurogenesis, but we'll have the answer to that. Because we have, you can look at, for example, the thickness of the Brodmann area 25 in depression. You can look at the thickness of that before and after treatment. So you can see if that gets thicker again. And also you can measure the synaptic connections. You can do something called a NOTI scan, which allows us to actually see how many dendrites and how many axonal connections there are. You can measure it directly now. So we'll be able to quantify this, but that hasn't been done yet. We have the data, and we'll be looking at that. But right now, I don't know. What I can tell you is function gets better. We can see that arterial spin labeling because that's a sort of an independent biomarker. But of course, if you do psychometric testing, and you've done this probably 1,000 times, where a patient comes in with depression and maybe you run some memory testing and they're in the 1 percentile. You treat their depression, and now they're 40th or 50th percentile. I mean, you clearly see that happening. Yeah. So yes.
Do you have any plans on doing research just to figure out how come when the treatment's successful, it lasts about 2 years? Did I understand that right?
Yeah, we have a 2.5-year average duration of benefit. Yes.
Are you doing any research, or will that just happen naturally with your program to figure out what the causes are for the benefit and why it degenerates again?
That's a great question. I don't, we have to learn more about this. So depression, there is a change, there is not just a functional change, but there's an anatomical change in the brain. And why some people start to excessively prune the connections in this area of the brain that's responsible, we don't really know what the inciting stimulus of that is. But there's definitely an inflammatory component. Here's something that I've known about since I was a medical student, and now I'm starting to make these connections again. You put patients on something that's pro-inflammatory, and their depression gets worse. You've probably seen this in your practices. So for example, interferon therapy, we've used that for treating like liver failure or other things, or other kinds of like vaccinations. I mean, think about some of the patients that you've all seen. This has happened. They come down with a bladder infection, or they have irritable bowel syndrome, or something. Something happens that's pro-inflammatory. What happens to their depression? It gets worse. Now, traditionally what we've been saying, well, they're sick, of course they're going to be more depressed, because they're not getting out of the house, they're not having the social interactions. But there may also be a direct connection. There's the inflammation that happens in your body probably turns on whatever this process is that affects this part of the brain is related to a pro-inflammatory process. So these things are all connected. Yeah. So we're about at 1:30. Why don't we call it a day? And if you guys have any other questions, feel free to come up. I'm here for you. Thank you.